Okay, let's quickly get through the second question. The second question reads, a P53 signature is best described as. Now we already have discussed in the part 1 of this series, the P53 signature has a benign looking histology. So benign looking histology, and the Ki-67 is less than 10%. Morphologically normal tubal epithelium, so this sounds correct, with TP53 mutation. So in the definition itself it says that it has started TP53 mutation, so this sounds about right. Then thirdly, we have PAX2 null secretory cell expansion. So often there is null expressed PAX2, which sounds correct, with BCL2 overexpression. So BCL2 expression is variable. It is usually overexpressed but may also be normal. So C is doubtful. And in the option D, we have a precursor lesion always is adjacent to the STIC. So this also doesn't sound right. So the correct answer is B. So we have a morphologically normal tubal epithelium with TP53 mutation and strong P53 staining. Now we have discussed all the options, but in the option D, often P53 precedes STIC lesion and are not always adjacent. So this is not a true statement. So this is it about P53 signatures. Now let's go through this third question. Which feature is required for diagnosing serous tibial intraepithelial carcinoma? So again, PAX2 expression is lost, but I don't think it diagnoses STIC lesion, so it is also doubtful. Ki-67 is less than 10%. Often Ki-67 is greater than 10% in case of STIC lesion. Thirdly, abnormal morphology, that is true, and aberrant P53 staining, which is also true, because it is these lesions are occurring beyond the TP53 signatures. That is, the normal sequence is TP53 signature, following STIL, and finally STIC lesion, and then we have high grade serous carcinoma. So all those lesions occurring after T53 have T53 signature, and Ki-67 is greater than 10%, so that is also true. So option C sounds about right. And in option D, we have presence of ciliated cells. So this is also not diagnostic criteria for STIC lesion. The answer is C, and it should require all three criteria for diagnosis, that is abnormal morphology with unequivocal nuclear atypia, aberrant P53 staining, and Ki-67 of greater than 10%. Now we have already discussed PAX2 loss is seen in SCOUT, but can also be seen in STIC, but it is not diagnostic. In option B, Ki-67 is less than 10%, which excludes STIC lesion because it defines the P53 signature, and STIC arises in secretory cells, and often ciliated cells are absent in this lesion. Now in the next question, STIL lesion differs from STIC in that STIL has a Ki-67 of greater than 10%. It is wrong because only carcinoma will have a Ki-67 of greater than 10%. So it is not diagnostic for STIL. Then the second option is it shows TP53 mutation, which is true, and the Ki-67 is less than 10%, which is also true. It lacks nuclear atypia. So here nuclear atypia has just begun, and it doesn't lack nuclear atypia, so there is some degree of atypia. In option D, it is always found in the proximal fallopian tube. So I don't think it differentiates with STIC because they are STIC and STIL lesion, they are both found in the fimbrial portion of the fallopian tube mostly. So STIL lesion is defined by T53 mutation, low proliferation index, that is less than 10%, and also they have some degree of nuclear atypia, and most often occurs in fimbriae.